Well, we're going to be staying in South Africa. We're just going to move slightly up the east coast of South Africa, but I'm going to discuss the context a bit later. Up front, I just want to acknowledge the International AIDS Society for their financial support, which afforded me the opportunity to be standing here in front of you and presenting on what I think are very useful and interesting findings. I also want to acknowledge my co-authors, especially Candice Reardon, who would have been here presenting, but she is away on maternity leave. Importantly, I'd like to thank John Simon and his team from the Center for International Health and Development, Boston University School of Public Health. So, the study that I'm going to present this afternoon really builds on a 2007 paper by colleagues who examined the Cinderella myth. Now, I'm hoping that all of you in the room can think back to your childhood stories and recall the story of Cinderella. For those of you who don't know, Cinderella was an orphan who lived with her stepmother and her stepsisters. You will also recall, hopefully, that she was ill-treated, ill-fed, and poorly clothed. Now this study specifically set out to determine whether the differences in well-being, which were defined by education and health outcomes, existed between orphans and non-orphans who live in the same household in the context of very high HIV prevalence and mortality. The data from that study, from the first 2 rounds of data collection, found no statistically significant differences in most education and health outcomes between orphans and non-orphans. So focusing specifically on this study and the context, we know that the majority of children, especially in South Africa, do not live in dual parent households. Kluwer, in her paper in 2011, records that being an AIDS orphan is often associated with more mental health distress and instances of post-traumatic stress disorder compared to those experienced by children whose parents are alive. A study conducted in Cape Town, also by Lucy Kluwer and colleagues, demonstrated higher levels of stigma and depression amongst AIDS orphans than orphans whose parents had died of causes other than HIV. But having said that, there's also a significant body of research which shows that AIDS orphaning is not a definitive determinant factor affecting the welfare of children. There is considerable variation in the results of studies, including no significant relationships amongst a body of South African research. This study focuses on the psychosocial welfare of orphans and non-orphans living in mixed households, measured according to anxiety or depression, affability, and resilience indices, and the effective relationship between the children and their caregivers, assessed in terms of children's communication with caregivers about personal problems, together with the material and practical assistance they receive from those caregivers. In addition to that, we also examined the engagement in substance use and sexual practices between orphans and non-orphans in mixed households. The study, as I suggested earlier, was conducted in KwaZulu-Natal in South Africa in a district called Amajuba. HIV and AIDS prevalence in Amajuba district has fallen from 2006, where it really was at a high of 46% amongst pregnant women. And it's fallen since then to 37% in 2009, which was during the study period. In terms of the sampling, random stratified cluster sampling based on age and on school registration was used to construct a cohort of orphans and non-orphans and their households from a random selection of 60 schools in a district which had in excess of 250 schools. Comparison, non-orphan children were selected from the same school by grade and age group. The paper which I'm discussing this afternoon utilizes the data from the final round of data collection of a longitudinal study. In terms of the analysis that we adopted, we looked at means, standard deviations, and frequencies to evaluate participants' overall scores for anxiety and depression, affability, resilience, caregiver interaction variables, and substance use and sexual practices. Further to this, we used correlations, chi-square tests, and ANOVAs to identify any important covariates of the outcomes of interest to determine whether these had to be controlled for in further analysis. So, turning to the results, out of the 623 households that were in our study, 134 of those were mixed households. In other words, 134 of those households had both orphans and non-orphans living in them. And these comprised of 61 non-orphans and 73 orphans from these mixed households. What we found was that orphans and non-orphans did not differ significantly from one another in terms of their gender or age. The mixed households from which orphans and non-orphans were drawn were relatively the same in terms of household size and household income. The important finding of our study was that anxiety and depression, affability and resilience showed no significant associations with any of the variables listed. Overall, child participants reported frequent communication with caregivers about their problems, while reported caregiver help and assistance was even higher amongst almost 2/3 of the participants, who suggested that they were always helped and assisted when required. As with the psychosocial outcomes, caregiver perceived assistance and communication with caregiver about problems were not associated with any covariates such as household size, monthly income per capita, child age or gender, or caregiver gender, and importantly, relationship to the child. As you can see, I hope from the table, overall the results showed a mean score of 37.32 for anxiety and depression, and I mention the score because 37.32 is slightly low, so there are clearly some signs of depression amongst the children in this study. However, the scores of 35.7 for affability and 23.35 for resilience were encouragingly high. Due to no significant associations, independent sample t-tests for orphans and non-orphans in relation to the 3 psychosocial outcomes were conducted. But again, this did not differ significantly between orphans and non-orphans in these households. These independent t-tests revealed no significant differences in the frequency of communication with caregivers about problems between orphans and non-orphans from mixed households. Both the orphans and non-orphans reported high levels of caregiver help and assistance with regard to practical help and material items such as money and clothes. The prevalence of substance use and sexual activity was low among the child participants. Child age, gender, and household per capita income were analyzed as covariates with these risk behaviors prior to assessing whether these health risk behaviors differed between orphans and non-orphans. Ever having smoked and having sex was significantly more likely amongst older children, as I guess we would expect. For those who are quantitatively trained in the audience, the Fisher's exact probability tests were run rather than chi-square tests due to the small sample size. The proportion of orphans relative to non-orphans who reported using alcohol or drugs did not vary significantly. To assess whether orphans and non-orphans differed with regards to sexual activity and smoking, hierarchical logistic regressions were conducted in order to control for some important covariates. So, just to recap, our study set out to determine if orphans from mixed households reported significantly worse psychosocial outcomes and caregiver interactions than non-orphans in mixed households, as well as differences in substance use and sexual practices between both these groups. Findings suggest that there is no difference in psychosocial outcomes between orphans and non-orphans. And I guess there are a few possible reasons that could account for the similarity in anxiety and depression, affability and resilience scores. Firstly, having close relatives such as grandmothers and aunties as primary caregivers may protect against some of the adverse psychosocial effects that can emerge from orphanhood. Apart from these caregiving relationships, living in circumstances of substantial poverty and deprivation may also account for the lack of differences in psychosocial outcomes emerging between these two groups. And this is supported by research by Quinlan and Gardner in 2006. So to continue with the analogy of Cinderella, and it's a clarion call by UNICEF as well. The call for the handsome prince to ride in and save the orphan. Our study certainly questions those social protection responses that are financial or material in nature and targeted specifically towards orphans or AIDS orphans in particular, given that both orphans and non-orphans from mixed households were relatively as poor as one another. Of course, this study is not without its limitations. Other studies have shown, however, that the type of orphanhood experienced or the causes of orphanhood may better account for variation among orphan health outcomes. Thus, as is the case with our study, being unable to distinguish between the type of orphan in our analysis, owing to the small sample size, and the cause of orphanhood is a serious limitation. So again, to reiterate, our findings indicate that orphans in mixed households were no worse off in terms of psychosocial indicators in comparison to their non-orphans. There certainly does need to be greater thoughtfulness in how we define orphanhood, as even children with living parents had other relatives identified as their primary caregivers. Essentially, in this context of high unemployment and where parents often migrate for periods of long time looking for work, caution is emphasized with regards to decisions being made about which children are considered most vulnerable in contexts of high poverty and high HIV prevalence, and to whom responses should be targeted, whether this is to be to orphans only or mixed, large, or impoverished households as a whole. Finally, we'd like to acknowledge those who participated in the study and our funders for their generous support. Thanks.